So I think we will start now with the introduction, and then the people will join during the discussion. So good afternoon. So to everyone, actually, this is a one of the this our final maybe before the ONCA World Conference Spice to GP Cafe from Sri Lanka. So I'm happy to invite you everyone here. So you all know we are continuing continue doing the GP Cafe for every month, doing the GP one of the GP cases. Actually, this is a very good initiative from this Asia. Actually, we are the Sri Lankan. We are initiate the this case discussion from the beginning. So from the other countries also they have actually now the as a region we do the a lot of case discussion. So in the view of background, so we will go for the this GPKV discussion. I'll cordially invite Dr. Shamin to moderate this session. Shamin, please go ahead, please.
Thank you, Dr. Govik. And good evening to all the participants and Dr. Sayanthan for joining in today. So today's GP's Cafe, we have a very interesting case, a discussion, prick and find the volumetric differences. And by a very experienced general practitioner who's been in practice for the last 13 years. So a few words of introduction about Dr. Sayanthan. He's a graduate from the medical faculty in Jaffna. And he has also obtained his diploma in critical care medicine in 2013. And currently he's an MCGP trainee in the 8th batch. Before we go ahead with the case presentation, a few rules. You can, interrupt and discuss and ask any questions, any sort of discussion or any case that you find similar to this, please share with us because it's all about interaction. Over to you, Dr. Sayanthan.
Thank you, Dr. Shamin, and welcome to you all. And today my presentation will be using hematological indices in general practice. It's being done with a case presentation. So there are several hematological indices, but in our practice we are using 3 or 4. That's enough for our practice. The first one is mean corpuscular volume. That's MCV. Average size of the red blood cells. The normal value will be 81 to 100 femtoliter. The second one is mean corpuscular hemoglobin. That average amount of hemoglobin in the red blood cells. That is also the normal value will be 27 to 32. The next one is mean corpuscular hemoglobin concentration. That is MCHC. In the discussion, we'll be going with these shortened forms. Normal value will be 32 to 36. The fourth one will be red cell distribution width. That is measuring variable sizes of RBC in the blood. Normal value will be 12.2 to 16.6. From this introduction, I'll move on to my case. My case will be, he is a 59-year-old male. He's a teacher, professionally he's a teacher, living in Karachi, Pakistan for the last 35 years. And came to Sri Lanka last June for the vacation and came to me on latter part of June with a presenting complaint of soreness of throat, voice change, taste change, and pain, hand pain of 2 months duration. Met few doctors in Pakistan, problem persisting. So there was no past history and no significant family history, but one thing he can remember, his mother has been on regular injection, but he's not aware what it is, and mother is no more living. And when we go to drug history, he's not on any regular medication, and social history, he's professionally a teacher, neither an alcoholic, nor smoker or illicit drug user, and he's a non-vegetarian. He used to consume fish and egg for 5 days in a week, meat once a week. With this, I started my examination. So he's mildly pale and having glossitis. And particularly, I checked for the lymph nodes as there's a pale, but no lymph nodes, absent lymph node enlargement. And cardiovascular system, mention it as CVS, not significant, that was normal. And respiratory system, again, not significant. And when I move to abdomen examination, he has no hepatosplenomegaly. So with this, so as a usual GP practice, patient presented with a vague symptoms, and we have minimal signs. And when we go into the eyes, that is idea, his idea, I have mentioned it in his words. I have been thinking that hoarseness of voice may be an early stage of progressive neurological weakness. That was his idea. And concern, as I am a teacher, I am worrying about these symptoms having an impact on my work. And his expectation was, I am hoping that you could guide me appropriate specialty. So this is a constraint of being a first contact, as you all have experience in your practice. So with a vague symptoms and minimal signs. So at this point, I have just gave him some simple painkiller and asked for the full blood count only. The next day, he presented with a full blood count. The full blood count shows hemoglobin was 10.6. Within bracket, the normal value 13 to 17. So obviously, there's a low hemoglobin. PCV packed cell volume was 34. That's also low. And white cell count is 5,160. Out of that, neutrophil 53, lymphocytes 23, and eosinophil 2%, but I didn't find any difference on that. And platelet, which was again normal, within normal limit, 197,000. So from this investigation, the impression was anemia, but other cell lines are within normal limit. But when I went deeply into the hematological indices, his mean corpuscular volume is 132. That obviously that's high. Within bracket is the normal value. Mean corpuscular hemoglobin is 41.5. It's also more than normal. And mean corpuscular hemoglobin concentration was 31.5. That's fairly lower limit of normal. But the red cell distribution with 20.3, that's higher than normal. So that indicates there's various shapes and size of the cells, red cells in his bloodstream. So here, after seeing this hematological indices, increased red cell distribution with RDW with increased MCV suggest B12 or folate deficiency. Then confirmation needs, ideally serum B12 and red cell folate level has to be done. But when I go into the cost, I have to discuss the cost with the patient. Serum vitamin B12 level at that time is Sri Lankan rupees 6,820 rupees. Serum folic acid cost around 8,910 rupees. Red cell folate cost 9,820 rupees. And the blood picture cost around 1,670 rupees. So after having a discussion with the patient, we have planned to go for the blood picture. That was a patient-centered approach. I hope that will be all right. Then blood picture was sent to the hematologist, consultant hematologist. The report is as as below. RBC, macrocytic normochromic red cells. White cells, WBC, mild neutropenia noted, hypersegmented neutrophil, as you all know, this is B12 deficiency indicating, but there's no abnormal cell-like hematological malignancy. Platelet was normal. So the conclusion by the hematologist, moderate macrocytic and neutropenia are due to B12 and folate deficiency. But at the end, hematologist has given suggestions. One is to do the B12 level. The next suggestion is trial of B12 and folic acid replacement for 3 months and review the response. Myself, and this is the blood picture report, just right. Myself and patient has had a discussion, and we have chosen the second option, and we have started the treatment. That treatment was like this: B12, 1000 microgram intramuscularly every other day for 5 days, 5 doses given, followed by once a week for 2 months, and then planned for once a month for 6 months. And same time, folic acid, 1 milligram daily for 3 months. As with the usual anemia treatment, I had to treat the worm. So albendazole 400 milligrams single dose was given. So patient is being with contact with me and recovery. So in 2 weeks time, patient showed symptomatic improvement. His taste change, voice change is getting better. So in 3 weeks time, we have repeated the blood count, so I'm comparing the blood count previous and the current one. Hemoglobin picked from 10.6 to 12.5. MCV 132 to drop to 109, but still it was high. MCH is 41.5 to 38. MCHC 31.5 to 33. RDW, red cell distribution width, again, it's still high. So it was planned to continue the treatment. Patient departed to Pakistan after the vacation, but treatment continued. He has repeated the full blood count in 3 months and contacted me. So I am summarizing those full blood count, all 3 full blood count. That is first one, hemoglobin on net when he came 10.6, in 3 weeks time 12.5, and now 13.4. And MCV 132, 109, and now fairly came to normal. It's within the normal limit, little lower than that. MCH again is in the normal limit, and MCHC more or less upper limit of normal, and RDW, red cell distribution width, is within the normal limit. That means there's no multivariable size of the RBCs in his blood. So I have advised him to do full blood count in 3 months' time. That is, again, a principle of family medicine or general practitioner, continuity of care. So this is my case, but of course, there is a gray area in this case. So in this patient, he is a non-alcoholic, non-vegetarian patient, but we are not sure what is the cause for the B12 and folic acid deficiency in this non-alcoholic, non-vegetarian patient. For the completion, we have to do TSH level and liver function tests, which were normal. So before going into the some theory part, if any comments or any questions, I'm ready and happy to answer. Well, so we'll move to some theory parts. Causes of macrocytosis in the blood. One is B12 deficiency. The other one is folate deficiency. and alcoholics, hypothyroidism, liver disease, and drugs such as reverse transcriptase inhibitors. As you all know, this is for the AIDS medicine. Convulsion means fits medicine, methotrexate, and sulfasalazine. These medications can cause. And primary bone marrow disorder, that is myelodysplastic syndrome, that was fairly excluded by the blood picture, that is white cell area was mentioned as no abnormal cells. And causes of increased red cell distribution with iron deficiency can cause it, B12 deficiency can cause it, folate deficiency can cause this red cell. So collectively, when we see the causes for the increased RDW and increased MCV, as in this patient, B12 deficiency, folate deficiency, and chronic liver disease. So B12 therapy, there are various recommended therapy. Just I am mentioning about one mode of therapy, B12 in the patient with B12 deficiency. This therapy is in this therapy, it's mentioned that B12 1000 microgram IM intramuscularly daily for 3 days, 2 weeks, then weekly until hemoglobin picked up. Then monthly for life. But patients with neurological symptoms, significant neurological symptoms, this treatment, we have to treat these patients aggressively. Nowadays, currently, you are aware that oral B12 also available, sublingual as well as oral, and oral B12 tablet to be taken in empty stomach. There are some prerequisites, and best time in the morning. Do not chew or bite the tablet. So that's, and foods. What are the foods rich in B12? Fish, meat, poultry, eggs, dairy products, fortified nutritive yeast, fortified cereals. That's all about the B12. Then folate treatment. Folate treatment, what they are recommending is folic acid 1 milligram daily. 1 milligram is 1 to 5 milligram. Though it is said like that 1 milligram is enough for 4 months, but the duration can be extended depending on the deficiency. There are some foods I can find out which is folate rich. Dark green leafy vegetables, beans, peanuts, sunflower seeds, fresh fruits, whole grains, and liver. So that's the end of this presentation. I would welcome questions and comments and any advices.
Hello, Dr. Sayanthan. This is Shane Halpe.
Yes.
I hope you remember me. Yes. So very nice. Thank you for sharing your case presentation. And it's a very not so common to come across patients having B12 folate deficiency, and you have managed it very well. And thank you for sharing with us. And I'm very curious that we were not able to find out the cause. Apart from, you mentioned about that patient is non-alcoholic and non-vegetarian. Were you able to go into a little more detail regarding the dietary history?
Yeah, definitely. There was a cause rare, not in our country, fish tapeworm. There's a tapeworm called fish tapeworm. That's mostly common in North America, coastal area of North America and South America. They are consuming fish as a raw. So I had to clarify from him, but he has he has not no habit like that. But there was retrospectively when I was reviewing this case, his mother, who has been taking one of the injections regularly, I don't know which, that can be a B12, but I couldn't find any genetic correlation in this deficiency. But medicine is vast, there might be. But the fish, he came from Karachi, Pakistan. So that's up to epidemiologists. We don't know what type of parasitic and microbial diseases are common in that area. So I was particularly asked about this raw fish consumption, but that's not there. But otherwise, his dietary history fairly includes non-vegetarian foods, and so we are very much particular about the non-vegetarian foods, which basically covers the B12 and the folate. I hope
The eosinophil count was normal, I suppose.
eosinophil 2%, yeah, 2% out of that 5,160. So that is fairly is the normal limit. But of course, as a anemia management, we used to give albendazole. But if it is a fish tapeworm, the treatment is different. Some other antihelminthic medication. But of course, I would prefer him to send his in a blood count in 3 months' time. Probably time will give some. That is also the one of the family medicine principle.
Thank you. Thank you.
Excuse me, that a patient, hello?
Yes, yes, I'm hearing.
I'm Dr. Sabrina, MCGP trainee.
Yes.
I want to ask the complaint of the symptoms. Did you mean he had numbness of the hands and?
No numbness,
Because
actually. He
no
complains
numbness,
of
no?
pain. He complains of pain, but of course, the main thing is a voice change and the
Changes.
taste changes. That's suppose initial my impression might be a post-COVID killer, but of course I had to investigate after seeing the pain. Hello.
And glossitis also, no?
And glossitis. I'm sorry I couldn't take that picture because now.
Hello?
Yes, I'm here.
And he's having glossitis and the voice changes only. No?
Voice
That
changes.
also,
Voice changes, taste changes.
So neurological part
Neurological
is
is
okay.
no, yeah, no numbness,
No any.
no.
After it's because of the B12 deficiency only, he's having such a symptom.
Because it symptoms improved. Actually, it's like a vague
Improved,
symptom,
no?
but
So,
symptoms improved.
thank you very much.
And one small thing, Dr. Sayanthan.
Yes.
The MCV you mentioned, it was 130 something, right?
132, yeah.
Yeah, I mean, I'm not very experienced. I mean, my practice is like about 3-4 years. So since my internship, I feel that is like a very, very high MCV. I feel there might be something underlying which probably genetic, as you also thought of, probably like an intrinsic factor problem or like some pernicious anemia. Maybe in about a year or 6 months, despite the replacement, he might be having a problem with B12 absorption.
Definitely. So I'm also curious on that. So I'm in contact with him. He's happy to follow my advice, and actually he asked me to send this presentation also.
Yeah. Thank you. Thank you.
So what can we do as safety netting for this patient to?
So ideally, that
as a follow-up
B12 deficiency
process?
more or less is a lifelong treatment. So though we have planned for though we planned for 3 months, it has to be lifelong, I feel. So hopefully with next full blood count, we'll be able to decide on that in our ground. Sometime we might have to refer to some specialist. But he doesn't have any symptoms of peptic ulcer disease. That also I have to admit here.
That's correct. That was very interesting and an eye-opener for a first-hand contact with the patient. At least something, before a doctor at the first contact can do. So do we have any more questions or anyone with similar experiences they would like to share? So I would like to present you with a certificate for joining us today.
You. Thank you very much.
And
Yeah,
I
thank you.
would like to invite Dr. Gobit to now continue.
Yeah, thank you, Dr. Sayanthan. That's a great, one of the good neurological issue from the referral or something and all. But anyway, as a primary care physician, so actually we do a lot of things to do. Actually, you can do much thing till the treatment or whatever the investigation, whatever things in the course effective manner. So you have done a great work. Actually, I'm glad that we have the GPs do our family physician and do great work. So we will keep it continuing. That's actually the simple case actually you have presented. But anyway, such a great details are there. Actually, we are think a lot. So with the simple full blood count, the blood picture, how can we go with that? So how can be that? So we don't need to do the very fascinated things and all things that. But anyway, as a GP, so we do miracle to our own patients. So thank you for that. Also, small announcement to you all, everyone. You know, you all know, normally every month we have the GP Cafe, the GP discussion. So if anyone willing, so you can contact us. Actually, I am the chair of the National Spice Route Young Doctors Family Physicians Forum. So also you will get the chance. Next year we are having hosting World Organism Family Doctors on Café South Asia Conference in Sri Lanka. So we are proudly we will have one of the pre-congress session as well with the young doctors sessions. So you will participate. You can join as a member. So the details will be there. So I will invite everyone to join. And also, so this is because the previously I told about that the how the our GP case discussion has gone to the evaluate. Actually, that even though maybe 1 month maybe bit long, but we could do the even the twice a week, even because simple discussion among self, what we do even the daily practice, even though we maybe they're busy, but how we do our daily things and handle our patients and how to do the cost effective and patient centered care like that. So thank you all for the participation. And you all know we have you can search this all the recording from the last 5 years, Spice Route Sri Lanka YouTube channel. So you can see all the recordings are there, and you can. We are happy to hear all the comments from you all. Thank you all.
Thank you.
Thank you, Dr. Gobit. Thank you, Dr. Sayanthan.
Thank you.
Thank you to all the participants who took their time off today to join us. Have a good night.
Thank you.